everyone. It's my pleasure to make this talk in the BIC Symposium to introduce our research work for the sampling inequality and the biases of AI models in the medium lower-income countries and areas in the neuroimaging studies. The first question is that why we consider the sampling biases in the neuroimaging studies. In this very excellent previous fact showed that even though we frequently use the HCP and the ABCD datasets in the neuroimaging studies, but the significant ethnic biases were found, especially for the white Americans in those datasets. To make matters worse, this study found that when we used the cross-race validation, the model performance becomes very poor than the within race validation. So those findings indicated the generalization failure in our big datasets. Furthermore, in addition to the large-scale datasets, the increasing sample size seems to be not helpful to increase the generalization ability in the AI models are not. Even though we increase the sample size in the AI model training and another computational models, but the generalizability and the external accuracy for the diagnosis on another psychiatric disorders seems to be not increased as we expected. So, those evidence indicates the generalization failure in the neuroimaging studies, which may come from the biased population in the model training. As a result of generalization failure, the medical science concerned the clinical translational failure in their field. In the AI science, the garbage in and the garbage out is the principle in their model training. And in the medical science, the biased data in and the biased diagnostic outcomes come from. This is a very high concern in the usage of AI models in the medical science. To check whether the exact studies have suffered from the biased data for the biased diagnostic result in the psychiatry. We conducted this systemic meta-research study to check whether those studies for the neuroimage-based AI models in the psychiatric diagnosis where comes from the biased population. By using the proposed and the clear checklist, we found almost all the models have suffered from high risk of bias, at least in one domain, such as the data, technological assessment, and the real-world application. By using the clear checklist, we found all the AI models and all the AI papers in the neuroimage-based psychiatric diagnosis were not enough to evaluate their real-world application. I extracted the demographic information from their samples. We found almost all the samples were coming from the high-income and the developed countries. To quantify how those samples were biased in those high-income countries, we utilized the mathematical models called the Gini values. We found the lower Gini values in the more economic developed countries than the less economic developed countries. And in those studies, we found a very high sampling inequality of those sampling population in the globe world. Also, within a certain of countries, we also found the significant sampling inequality, such as in the American. We found those states or the cities with high income showed the higher populations for the AI training. Even though within the China we found the high to medium income cities and states showed more sample size in AI models training. And this pattern was also observed in the Germany. By using the Gini values, we make some statistics for those countries such as China, America, Italy, Germany, Paraguay, UK, Japan, and others to examine why the sampling populations was biased in those countries. We hypothesized that the country and the city incomes would predicted their sampling populations. We found that the GDP is a significant predictor to the sampling inequality in the China, in the American, and in the global world, with the higher GPT could predict the higher sampling populations in those AI model training. To address this biases, we finally proposed the checklist to guideline further usage of those studies, such as the neuroimage-based machine learning model assessment checklist for the psychiatry and the REM, that is the reporting guideline for neuroimage-based machine learning studies for the psychiatry. This is the checklist, and this is the diagram to guideline the future neuroimage-based AI models to avoid the sampling the population biases in their studies. Okay, beyond those AI training, we further probed into whether the mature AI models suffered from the same problems in the AI usage. In addition to those developing AI models, those mature models was developed to the real-world clinical practices. Also, by using the meta research studies, we firstly found that the neuroimage technologicals were still the mainstreaming technological for the AI models training, such as the CT and the MRI, including the fMRI. And the cancer detection is also the mainstreaming of those mature AI models in the medical application. By extracting those testing sets, which is the patients in those real-world usage of those mature AI models, we found the AI models could only benefit for a certain of countries for their patients, such as the China, the American, and the Canada. Even within the China and within the America, we found that those patients who were diagnosed by the mature AI models diagnosis comes from the high income cities or the states. So we further compared compared whether those mature AI models were come from the same country. We found less than 1% papers reported for diagnosis by the AI models that trained from the different countries, such as we trained with AI models by the Chinese population and used it for the American patients. Furthermore, we found even within the same countries, less than 3% papers reported for diagnostics by the AI models that trained from the different cities. In the last findings, in those across country or across city diagnosis clinical development, 13 or 42 papers reported the poor AI model performance compared to human decisions, which means that when we use the mature AI models in the clinical development, the across country or the across city diagnosis in the AI model and diagnosis, it's not better than the human decision. Okay, we further compared the specific model performance for the within country, across city or states within the same country, and across race, and we found the AI models could perform better only in the within country. That means we trained these AI models and testing these AI models in the same country. The AI model performance could be better only in that situation. Lastly, we want to introduce its other insights. Is this problem exclusive in the brain AI models? We tried to prove whether the sampling biases in another studies, such as the COVID-19. Okay, by extracting the population details from those studies published in the COVID-19, we found the same pattern that showed the almost all of the population were sampled from high income and the upper middle income countries and the races. Okay, take home message. For the first one, at the neuroimaging-based AI models training stage, the significant sampling biases emerged, particularly in showing the economic inequality. The less economic developing countries showed almost threefold sampling inequality than the more economic developing countries, especially for the African. Beyond the developing AI models, in the clinical development stage from those mature medical AI models, the ethnic and the economic inequalities still existed, with exclusive benefits of those AI models on the patients. The AI models to the patients in the real-world clinical practices may be substantially limited to the weird samples because of that sampling biases at the training stage, because we found the AI models could only outperform than the human decision when training and testing in the same country population. Lastly, such sampling biases and inequality are not limited to the brain or the neuroimage-based models, but also for the behavioral studies in the COVID-19. Okay, many thanks for the course-in and the OHBM invitation and my PhD student research team. Welcome to all the questions, and many thanks for your attentions.